Good morning, everybody, and welcome to sunny Saskatoon. Oops. I swear to God, it hasn't rained for 2 months. So one of you brought it. My name's Tim Archer, and I'm the Executive Director of the Saskatoon Community Clinic. And I'm also a CACHC board member, and I'm really pleased to be your local host over the next couple days. I really do hope you'll take some time out to get, even in between the little spurts of rain, to walk along the riverbank and enjoy this great city. I see a few people have, that's great. It really is a well-kept secret that Saskatoon is a great community-minded city. We have a really exciting slate of sessions for you to get engaged with over the next couple days. But certainly not nearly as valuable as your active participation. So because we're a relatively small, what I'm saying, an intimate group here, I'm going to put this challenge out right now for you to be provocative and challenge the status quo, which I know that many people around the room have no trouble doing. We really need you to provide some disruption, even some uncomfortable disruption, so that we can make meaningful change happen. So a couple housekeeping items. Washrooms. There's a set of washrooms right at the entrance to this room, and there's also another set on this floor. If you go towards the elevator and the Oak Room and then turn right, there's a hallway and there's some more washrooms there. There's also washrooms one floor up. Also, emergency exits. There's an emergency exit just around the corner here, and there's one again out the entrance to this room up the stairs. So there is a weak Wi-Fi if you can pick it up down here. It depends kind of where you are and which way you're leaning, that sort of thing. It's a Parktown guest, and then there may be a login that it might take you to a login, and the code is Parktown1, all lowercase. So here in Saskatoon, birthplace of Medicare in Canada, we take great pride in the legacy of where we have come from. This quote was kind of given to me a couple days ago by Scott, actually, not surprisingly. If I've seen further, it is by standing on the shoulders of giants. Now this quote is attributed to Bernard of Chartres, probably butchering that name, popularized really by Sir Isaac Newton, who in the late 1600s expressed recognition and appreciation for those who pioneered before him, setting the stage for his own enlightenment and discovery. We are very fortunate to have among us some giants. I'd like to ask Dr. John Burry and Mrs. Betsy Burry to please stand. I know they're in here. John and Betsy, who many of you met last night at the reception, were here at the beginning of the Medicare crisis in Saskatchewan in the early 1960s, where they fought for what we have. John as a physician, Betsy as an eventual member relations and patient ombudsman, both here at the Saskatoon Community Clinic. And not surprisingly, both of them continue the fight to improve, to enhance, and reach that next level, that second stage of Medicare. John and Betsy and others like you, there's many more actually in Saskatoon that are passionate protectors of our wonderful Medicare. We salute you. Okay, I'm not much of a speechwriter, so we're going to move on. We're going to try to move on quickly so that we can get to the really good stuff. At this time, I'd like to invite Andrea Wagner to the stage. Andrea is a Director of Primary Health who will bring greetings from the Saskatchewan Ministry of Health. Andrea?
Hi, thank you, and welcome on behalf of the Ministry of Health. Welcome to this conference, and welcome to Saskatoon and Saskatchewan. I'm from Regina, which is our kind of rival city, but Saskatchewan we know is the most beautiful province, and we're all very proud to be from here. In May 2012, the government of Saskatchewan released a new framework for primary health care called Patient-Centered Community Design Team Delivered, a framework for achieving a high-performing primary healthcare system in Saskatchewan. And the framework really sets the stage for strengthening primary healthcare in the province. And it points to a kind of a system-wide focus on community engagement, patient and family-centered care, contributing to a system that gets and keeps people very healthy, and a focus on continuous quality improvement, outcomes, and measurement. And I know that these are themes that align really closely to all of your hearts, the people in these rooms, this room, and to the work of the Canadian Association of Community Health Centres. And those themes also align really closely with the work of the community clinics here in Saskatchewan. And I know you'll be visiting Westside Community Clinic, but I just want to tell you that each community clinic in Saskatchewan works really hard to meet the needs of the community. Community engagement, the foundation of community clinic work, and what we want to be the foundation of primary healthcare work in Saskatchewan. So I'll just tell you a little bit. Westside Community Clinic in Saskatoon delivers really great primary healthcare services, but is also really focusing on the needs of that inner city population, delivering really unique services to folks with HIV. In Regina, the community clinic provides integrated primary healthcare, but is also looking at mental health issues for our growing immigrant and refugee population. In Prince Albert, they have really unique services for people with chronic conditions, including some respiratory therapy programs and a new focus on case management, which is emerging as an important part of the new primary healthcare model in Saskatchewan, case management. And in Wynyard, they provide primary healthcare services to a rural community, which is important here in Saskatchewan, like I know where you're from. So the Ministry of Health is really pleased to be partnering with community clinics, regional health authorities, communities, and patients and families in pursuing our collective vision of a primary healthcare system that is patient and family centered, that is stable and sustainable over the long term, and that contributes to a really exceptionally healthy population. So that's a little bit about what we're doing here in Saskatchewan. I just want to thank you all for the work that you do every day, your daily work, but also for coming here to this conference that looks really exciting, to sharpen the saw a little bit, to learn and share together so that you can go back to your communities and continue to strengthen the services that you provide for the folks that we all work to serve. So thank you very much. Good luck. Have a great time. Thanks, Tim.
Thanks, Andrea. I have to say, just a little plug, that the ministry has been very supportive as we move forward to improve and enhance the health of our community. So thank you for that. I'll now call on Jane Moloney, who's the chairperson of the Canadian Association of Community Health Centres, who will officially launch the conference.
Good morning. Good morning. Welcome, bienvenue. I am thrilled to see the room full of faces. I said when I got on the plane I was coming here, I felt like I was coming to have a get-together with family, and it feels like that. I'd first like to acknowledge the people whose land we're holding this meeting on, the Plains Cree. We recognize and acknowledge that to stand here and to hold our meeting here is a privilege and not a right. I'd also like to say, as we begin our celebration of our achievements and we look forward to our future growth, that I just want to take a moment to reflect on two really important aspects of things that join us together as community health centres. The first of that is the people, you, the people who work in the community health centres and sit on our boards and volunteer in our health centres. We are, in many respects, a family. And when one of us is hurt, we're all hurt. So I'd like to extend our condolences to the members of the CHC family in Ottawa, whose lives have been touched by the tragic deaths in the bus and train crash on September 18th. It affected 3 community health centres directly, and indirectly it affects us all. So thank you for those of you who've made it, and our condolences to those who can't make it to be here with us today. The second, we often forget this bit, and I'm really glad that I was in a meeting on Monday, And we were talking about providing services, the community health centers providing services to people who are not insured, who don't have medical coverage for one reason or another. And we're talking about policy, we're talking about processes, we're talking about funding. And Lynn Raskin, where are you, Lynn? Over there. So Lynn Raskin says, but what about the people? What do they look like? Who are these people? They're not even in this conversation. And I thought, you know, we can get there. We can sometimes really forget to talk about who we serve and why we do the work that we do. And so I had a little think about that, and I thought, you know, particularly, and thank you to the fact that at this conference we have some representatives from the communities that we serve. I think it's really important to make sure that they're always in the room when we're having conversations about meeting their needs and supporting their communities. We need to keep them front and center in everything that we do. And I thought about, you know, how are we affected by the people whose lives we touch and whose lives touch us? And I thought, you know, we're inspired by their resilience. We're educated by their resourcefulness. We're enriched by their creativity. We're touched by their kindness. We're humbled by their generosity. We are enriched by their humor. We're motivated by their persistence. And we are overwhelmed by their integrity. What this does is it means that we're saddened and angered by their challenges. We're furious at the stigma that they experience. And we are fiercely protective of their vulnerability. That's why we do what we do. And it's why I'm so happy that I can be in the room with you and that you're here to help us build on this movement and to continue to remember who it is that we're here for. I'd like to thank our sponsors who make what we're doing here today possible: the Affinity Credit Union, the Rio Translation Network, the Association of Ontario Health Centres, the Saskatchewan Health Quality Council, and Fairwear. They're the ones who recycle the lanyards that you all have around your necks. I'd now like to introduce Simone Thibault. Simone is the Executive Director of Centretown Community Health Centre. She is a CHCC board member, and she is the chair of the French Language Services Working Group. Simone.
Bon matin. Bon matin. Je vais expliquer qui je suis au niveau ethnique parce que la dernière fois, j'ai fait une conférence en français, c'était en Belgique, puis je représentais l'association. Et ils m'ont tous dit, Simone, parle lentement, articule. T'as un accent. Je dis, ah, j'ai un accent. OK. Je suis une Acadienne, la baie Sainte-Marie en Nouvelle-Écosse. Mais je suis une Franco-Ontarienne adoptée par l'Ontario parce que ça fait 32 ans que je demeure à Ottawa. Puis je vous dis ça parce que c'est important de comprendre la diversité de notre communauté francophone, y compris nos Haïtiens, nos Africains, nos Asiatiques, etc. Puis je vous dis ça parce que c'est important pour moi, comme présidente du groupe de travail, de m'assurer que partout au Canada, on a des services en français pour toutes nos populations francophones. Parce que ce n'est pas nécessairement équitable, et on le sait. On a certaines forces au Québec, on a certaines forces dans certaines parties de l'Ontario et dans d'autres provinces. Mais il faut s'assurer qu'on comprenne c'est quoi la réalité de toutes nos communautés francophones au Canada et qu'on s'assure qu'on porte attention. Alors, le groupe de travail, la première tâche qu'on a cette année, c'est de regarder c'est quoi l'état des services dans chacune de nos communautés partout au Canada. Et qu'est-ce qu'on peut faire comme association nationale pour faire le point aux décideurs provinciaux, territoriaux et fédéraux. Alors, c'est ça notre mandat. Et je sais qu'il y en a vous dans la salle qui font partie du groupe de travail, qui supportent le comité de travail. Mais on en encourage d'autres. Alors, puis on en encourage d'autres de d'autres provinces. Puis c'est super important. Puis je vais vous donner une anecdote pourquoi moi, personnellement, je trouve ça très important. Cette dernière année, ma grand-mère de 100 ans était mourante dans un foyer acadien en Nouvelle-Écosse. Et je l'ai visitée 6 fois. Et chaque fois, il y avait des choses qui étaient formidables dans ce foyer-là. Les gardes-malades appelaient ma grand-mère grand-mère. Ils donnaient un bec le soir. La dorlotaient, parce que ma grand-mère était facile, elle était de grande qualité interpersonnelle. Mais de temps en temps, elle regardait une nouvelle qui arrivait à son lit, puis elle disait « Do you speak French? » Parce qu'elle n'était jamais certaine surtout les fins de semaine, surtout les longues fins de semaine, si la personne pouvait lui parler dans sa langue. Et ça me cassait le cœur, parce que vraiment, dans tes derniers jours, où ta langue à toi est francophone, française, et où que tu n'es vraiment pas bien, c'est dans ce temps-là que ça compte. Ça compte toujours, du début à la fin. Mais quand ta fin arrive, ça compte. Alors, c'est juste un reflet, comment c'était important au niveau personnel pour moi, mais aussi professionnellement, toutes nous autres. On a toutes des histoires pareilles, puis je compte sur vous autres de travailler avec moi pour faire une différence dans les prochaines années, qu'on fasse vraiment un impact auprès de nos décideurs pour qu'ils comprennent c'est quoi cette réalité. Alors, merci. Là, je vais changer de langue. So, I have the great privilege to introduce Michael Rachlis, and I thought, well, most of this room must know who Michael Rachlis is. You read the bio. Last night I was looking for some other scoop, though. How do I present Michael Rachlis? So I spent some time beside Michael Rachlis last night, and there's two things, because I've worked with Michael Rachlis in meetings and stuff in Ottawa, and what struck me about Michael is he connects the dots in many ways. But I realized how he connects those dots by two things I heard and witnessed last night. One was his conversation with Anna Reid as the former president of the Canadian Medical Association, who's also a doc. And we all have docs in our lives, but there's something special about Anna Reid and Michael Rachlis, how they were describing how they started their career as physicians, how they worked in that career, and Anna still works in that career. And it struck me, it's exactly how we would want physicians to think. They think about the person in front of them, how do we make it work? The hours, whatever we need to do will be done, how they work with others, going the extra mile. Being paid $23,000 at Southwest Riverdale didn't really matter to Michael, he said, I think. But anyway, sorry, Lynn. Physicians weren't well paid way back then. But now they're pretty good, I think. And so it was just an interesting conversation about two physicians who cared, who have a lot of heart, who really, you could tell, they understood patient-centered care, client-centered care. The other piece that I always value from Michael, and that we'll witness when he talks about setting the stage and moving forward, is we can't move ahead if we don't have our corporate memory and history. And what I appreciate with Michael, he's an encyclopedia about how Medicare started in Canada, how it moved forward, why we are where we are now, and why community health centers matter. So I welcome Michael to come and give us a talk today, because I think it'll be inspiring as usual.
Thank you so much for that, Simone. And I should add to Lynn that I don't think you need any doctors at South Riverdale, but the good news is that I probably would work for $20,000. I started with $21,000 was my salary, but the bad news is that I only have my Ontario license until I try to use it, because I haven't practiced any medicine in 15 years. But I'm just thrilled to be here. That I do a lot of presentations every year, but there are some that are special, and this kind, and some of you will know, I've spoken to CHC groups before, that speaking to this group is very special to me, because this is sort of where I came from, so I feel like I'm with my family. And of course that means that I feel an extra pressure to give you a good presentation, and I have to do it within 30 minutes, so we'll have some time later for others and for other presentations and some questions. I've asked Tim Archer to give me a high sign in 25 minutes so that I can start talking extremely fast. So we've got, and the title, The Promised Potential of CHCs, Building on the Legacy of Douglas and Hastings, and this was a wonderful opportunity for me. I know all of you have yours at home. You didn't bring yours, but I've got copies of the 3 volumes of the Hastings report from 1972 with me, and it's been delightful reading them the last couple of days. So this is what I'm going to talk to you about, a historical overview of where we've come from, then a little bit about where are we now, and then where are we going, and then I want to make, I think I may be foretelling or foreshadowing what Scott will be, and Jennifer, I think, are going to be saying, that it's clear. I think you know that that Canada needs CHCs, but it may not be so clear to you that CHCs need Canada, and so I'm going to talk about that as well. So, let's see. So this is how I've chosen to divide this up. And you can see why it was a challenge to try to squeeze it into 30 minutes. So I'm going to give you a historical overview, sort of starting around Confederation, and would welcome, you know, Stephen Lewis's in particular, but others' comments on how to divide up the time periods. But I've sort of chosen these 7, I guess, eras in CHC history. So first of all, in the first period from Confederation, it's interesting, you know, as growing up in Winnipeg, Confederation was 1870 for us, but of course now that I'm in Ontario, and the world hardly extends north of Bloor, that I'm more focused on my adopted province perhaps. So, but medical regulation, during the 19th century, the early part of the 19th century, there's no regulation, that there's a few people who call themselves doctors. Typically, they're former military surgeons. And then during the 19th century, there's an explosion of other kinds of providers. Those military surgeons, going back to the 18th century, really, are what we would call allopathic physicians. They're the physicians like Benjamin Rush in the 18th century, whose colleagues helped bleed George Washington to death. You know, George Washington had pneumonia. But his recovery was not assisted by the fact that they took several units of blood out of him because it was felt that was a good thing to do at the time. So those are the allopathic physicians. And then during the 19th century, you have the development of homeopathy, Thomasonians, herbalists, later in the 19th century, chiropractic. So there's a whole bunch of different schools of medicine. And the allopathic physicians are getting nervous about all of this because there's a lot of competition for patients and for fees. And so during the 19th century, it's primarily the allopathic physicians who start petitioning state and provincial legislatures to regulate the practice of medicine. And we're of course, this is a room that knows the counter history, I suppose, but that typically in Canada we're told that this was done to get rid of the quacks who were selling snake oil and protect the public. But of course there's very much another side of that, which is the allopathic physician squeezing out the other branches of medicine. And in fact, the original College of Physicians and Surgeons has homeopaths on it, some others, and the last non-traditional doctors, in fact, on the board of the college last until the early 20th century. As medicine develops, the Canadian Medical Association, which is established in 1867, and the Ontario Medical Association, which then, and arguably even now, but especially then in English Canada is dominant, not only try to squeeze out other doctors, but there's a wonderful history of how the VON gets founded by Lady Aberdeen, who's the wife of the Governor General at the time. And she in 1897, the 60th anniversary of Victoria's ascension to the throne, she wants to have established a nursing order, just as the Jubilee nurses in Britain had been established in 1887 of the 50th anniversary. And she runs into a big problem, which is the Ontario Medical Association, especially, which keys the CMA response. And they don't like this. They see the nurses and their role as potentially very threatening to doctors and their fees. So the eventual agreement, which we see throughout history, the next 100+ years, is that the OMA agrees and the CMA agree that these nurses can work where doctors don't want to work, right? So there must be a few nurses in the room. So that sound familiar? So and the VON does get established, but the model for the VON, which is a district nursing model, it's a focus on primary health care and the determinants of health, which at that point were just as basic as clean water, for example, and the disposal of sewage. That never takes off in in mainstream Canada. The VON works in urban slums where doctors, by and large, don't want to set up practice, and in remote areas. And World War I leads to the establishment of the Federal Department of Health in 1917, and Liberal leader Mackenzie King, who takes over from Laurier, promises Medicare in the 1919 election platform. Only takes 46 years to fulfill that promise. Now, wars are good things for health. You might be surprised to hear that. Why are wars good things for health? Because governments are mainly concerned about the health of the population, and war, because in both the First and Second World Wars, it's that in Canada, especially in Britain, it's just scandalous. They're recruiting all these guys to go fight in France, and they're so unhealthy they can't put them in the army. So it's as simple as that. But there is more of a focus on health and healthcare that comes out of the First World War and the Second World War. And of course, establishing healthcare for veterans also puts the public foot big time in the door of publicly financed care. Okay, so then after Mackenzie King makes his promise, their provincial medical associations consolidate their control over medical practice. And one of the big things that happens is that up until about the First World War, most medical care is actually provided in people's homes. Even well into the 20th century, we've got doctors taking out tonsils on kitchen tables, but a lot of surgery was done in people's homes. A lot of healthcare was delivered in people's homes. Then healthcare gets increasingly consolidated in hospitals, coincidental with the rise of scientific medicine. And then it becomes really easy to control a practice of medicine, because if you don't have access to hospital privileges, you can't really have an effective medical practice in most communities. There's a few alternatives to fee-for-service private practice which develop, but not many. And is there anybody here from Mount Carmel in Winnipeg? I can't see, the lights are so bright. And the answer is no? No. Online, good. Well, congratulations to the folks at Mount Carmel in Winnipeg. As far as we know, that is the first community health center in Canada established in 1926, coincidental with my parents' birth during Winnipeg, in fact. During the Depression, that as the population gets more and more accustomed to medical care, then all of a sudden people are thrown out of work, the economy is a disaster, doctors suffer financially too. And so then there's a lot of conflict between doctors and the provinces on whether or not doctors are going to treat people on social assistance. And in fact, doctors in Winnipeg in 1935 go on strike, saying they're not being paid enough to look after these people. So this starts, really kicks in big time, the notion that doctors' practices can be blended, that the public, hopefully the public will pay for people who can't pay privately, and then people will pay privately. And then, of course, that people who can't afford to pay often get care in outpatient clinics, and then people who can't afford to pay go to private practice. And Western provinces flirt during this time with public health funding. In Saskatchewan, even before the NDP or the CCF wins government in 1944, there's quite a big public footprint in healthcare with municipal hospitals, payments for municipal doctors. And even in 1943, which is it's an interesting year. It's the turning point in the war, but of course, public policy is always a year or two behind. So Canada is desperate to beat the Germans. One of our major allies, in fact, our ally before the United States comes into the war, is Russia. All of a sudden, after being told to hate communism, we're told that the communists are our friends. And social policy moves left. And in fact, in 1943, if an election had been held, the NDP might have well formed a government because they're leading the polls at that point. So the whole body politic moves to the left, and the CMA sort of even hints that they could support public health care. And CCF wins government in Saskatchewan in 1944 and implements the first universal public insurance program in January 1st, 1947, the hospital insurance program. Now, after 1947, there's some hospital programs developed in Alberta and British Columbia, not universal, but there's more public support. The UK establishes the National Health Service in 1948, which becomes a beacon in Canada for public health insurance. And labor and some employers support group practice. And this is quite interesting that during the 19th century and then into the 20th century, that particularly in remote logging camps and mining camps, that people need health care. Doctors are not going to these communities by and large. There needs to be some medical care provided. So whether it's the employers who set up the company doctor, or whether it's the employers and employees jointly running a health plan, or in a number of cases, whether it's maybe the union through its welfare programs running health care, you get so-called contract practice, which, of course, medical associations in Canada and the United States abhor. And again, it's sort of tolerated in these remote areas, but not, but there's a lot of conflict when it extends beyond that. And in the United States, Henry Kaiser joins up with the surgeon Sidney Garfield in the 1930s as Kaiser's construction company is building the Grand Coulee Dam, and to provide health care for these workers. And then Kaiser decides this is a pretty good model, and with Garfield, he creates the Kaiser Permanente system, which is the largest not-for-profit but private healthcare delivery system in the United States. Group Health Puget Sound of Seattle was created in 1948 as a cooperative, still run as a cooperative, services 600,000 people, and they pioneer what in those days is called prepaid group practice. In Sault Ste. Marie in the 50s, John Barker and other folks associated with the United Steelworkers of America start to mobilize to create what will become group health in Sault Ste. Marie, which opens its doors in the 1960s. But there's the background of the Cold War of all of this, because now Russia is our enemy again. In fact, we've got ex-Nazis running Germany and Austria and developing our missile program, or the U.S. missile program. And Morris Fishbane, the irascible editor of the Journal of the American Medical Association, declares that group practice is tantamount to communist cells. And the pro-Medicare coalition, which includes labor and social justice groups, is advocating for public finance, but also a different way of delivering services. And it's really that during that time, now we're starting to get to the time that I can vaguely remember, and some other people in the room will remember better perhaps, but that it's really, I didn't see any difference between fighting for Medicare and fighting for a different system in the 1960s. So, but the politics of the Cold War are very harsh, and we can see the echoes of this with Ted Cruz, the U.S. senator who was filibustering over the last couple of days against Obamacare. And what he's saying about Obamacare is basically, and unfortunately, it's got resonance with tens of millions of Americans. But he's basically saying it's communism, that this is the end of freedom. Who's familiar with Hayek's Road to Serfdom? No, well, I strongly recommend you read it. Friedrich Hayek was the leader of the Austrian School of Economists, identified as being on the right, that give me liberty, give me death. His book, the Road to Serfdom, in fact, is almost indistinguishable in philosophy, and in my view, from John Maynard Keynes' philosophy, which is basically that the private sector does some things well, but you can't have the effective private sector without having an effective public sector. And one of the things the public sector should do is provide health care. But unfortunately, everybody in the U.S. who quotes The Road to Serfdom, which is most of the folks on the right, has never read it. It's just like the people who quote Adam Smith, the Scottish economist, who talked about the invisible hand, but also talked about the very important role of the state. In the meantime, because they're fighting communism, the American Medical Association sees that it's up to them to take the fight to where the fight against communism occurring, which is in Saskatchewan, and gives in 1961 $1 million, which would be the equivalent of probably at least $6–8 million today, to the Saskatchewan College of Physicians and Surgeons to fight Medicare. So then what happens? Well, that the federal government passes its hospital legislation in 1957, that now means, because that legislation gives 50% of the funding to the provinces that bring in a hospital insurance program that meets the federal terms and conditions, that means Saskatchewan's got a bunch more money, and they use it to plan Medicare. But I think this is mentioned on the first slide. During that time, there's, and again, there may be some people in this room will know this better than I, but there is tension within the CCF, of course, between those who, at least to some histories, are more associated with labor, who really want to focus on public finance, and others who really want to focus on public finance and a different delivery system. But as it becomes clear the Saskatchewan doctors are going to fight this really hard, the focus does become on simply an insurance system. The Medicare legislation is passed July 1st, 62, then the next day or that day, over 90% of Saskatchewan doctors go on strike, refuse to see patients, even in emergency departments. Citizens rally. Some UK doctors come in, like Dr. Berry, and the creation of the Community Health Service Associations, which create community clinics, is a major reason why the physicians ultimately have to settle the strike. After 23 days, the strike is settled, but it's an insurance model that's adopted. The Saskatchewan has been through a civil war, and it's really, this is something that lasted decades. As I would visit Saskatchewan, it took really until the 90s, where the wounds started to heal over. There were siblings that didn't talk to each other for decades. It was sort of as vicious as we could get off the ice. But the CCF, out of this, has little appetite to fight doctors and change the way they do their work. And there really isn't much understanding by the population, just as there's really primordial understanding now that, the way services are delivered, the way physicians and others are organized is absolutely crucial. What we tend to hear is, like many provinces now, family physician for all by whatever year, and as if that's going to be the answer to all our problems. So then, in response to Saskatchewan Medicare, because of the conflict here, Saskatchewan, well, he was born in Ontario, but John Diefenbaker grows up, in fact, in Saskatchewan, and he appoints a friend of his, Justice Emmett Hall, to chair a Royal Commission on Health Services. The Royal Commission recommends a broad array of services be covered, including home care and drugs, et cetera, but the 66 Medicare legislation only covers physician services. And Ottawa pays half the cost of provincial hospital and medical insurance plans. And in 1971, the Canadian Ministers of Health appoint Dr. John Hastings, who's then a professor at the University of Toronto, to review medical care. And of course, that I haven't gone into the social movements of the 30s that are very important as well. But in particular, I think for CHCs, it's the 60s new social movements, the women's movement, it's the environmental movement, it's kids who want respect, and as a result, we get a number of different new models of care that are developed, whether it's Clinic with a K in Winnipeg. Anybody from Clinic here? Yay! We've got and Centertown starts off as a street clinic in Ottawa. The Hassle-Free Clinic in Toronto is still a street clinic. Reach Clinic starts off in Vancouver as a street clinic for kids. And that there's all the stuff back then we see echoed today. And in fact, without those new social movements, we don't have, I think, a lot of the juice that still drives many of us today. The Hastings report on community health centers is established for 3 reasons, and it's just reading the 1.5-page rationale for why they get established. It is just eerie, right? That history repeats itself continually, that there's concerns about the rising costs of healthcare. Better primary healthcare shows that it appears to show that we can control costs in the system and lead to better sustainability. And there's also, it looks like CHCs can provide higher quality, and the phrase is people-centered care. Isn't it amazing, that the healthcare system just discovered patients a few years ago, sort of the way in 1492 the Columbus discovered America. And on that note, I've forgotten, but I do want to note that, of course, we're on First Nations territory. The territory represented by Saskatoon Tribal Council, which includes 7 First Nations communities. So just as Columbus didn't discover America, you know, the healthcare system didn't just discover patients a few years ago. The report recommends, and it's, again, it's wonderful reading, the immediate purposeful reorganization and integration of all health services. In other words, it's talking about the whole enchilada, not just community health centers. Most provinces have some response to Hastings, and some provinces do start to develop them. Initially, the medical profession is neutral, but within a few months, they're very harsh in their condemnation. The Canadian Medical Association, provincial associations is claiming that this is, again, this is basically contract medical care, and that there's something wrong with a doctor who is on salary, particularly if it's to a community group. In 1975 in Ontario, there were 11 CHCs that have promises of funding. South Riverdale and Lamp, in fact, were the last to be included in that, but there were up to 60 others in some form of development. The program was then frozen. There were over 30 community health service associations in Saskatchewan in 1963, but only 5 community clinics survived. How different would be the landscape of Canadian healthcare if we'd actually developed those centers then? In 77, the feds implement the Established Programs Financing Act, linking the hospital and medical care acts together, and ending the 50% block funding, and it signals the start of their exit from healthcare, although it isn't necessarily seen that as the time. In fact, shortly after South Riverdale opens in 76, we're about to be killed off. And it's only through some tough meetings with the then Minister of Health, Dennis Timbrell, and the fact that we knew he was a closet smoker. So for the younger people in the room, the old days, you could smoke anywhere. Dennis Timbrell was a closet smoker, but as Minister of Health, he couldn't buy his own cigarettes. We strategically positioned Charlotte Stewart, a Presbyterian minister who smoked, so that whenever his aide said he had to leave the room, she would flash her pack and offer him a cigarette. Could you believe that? So, CHCs in Ontario fight off their execution. And Larry Grossman, an enlightened conservative minister of health in 1981, is really the person who saves them in Ontario, points Fraser Mustard to review them, and of course Fraser Mustard recommends full speed ahead, and Ontario CHCs start to slowly grow. Later in that decade, Minister Eleanor Kaplan, with Deputy Dr. Martin Barkin, tries to get every MD off fee-for-service. This leads to massive growth in CHCs and HSOs, which is a bit of a disaster, actually, but the CHCs grow rapidly. In the meantime, Quebec CLSCs grow rapidly and become cornerstones of the province's system. But there's not much that happens elsewhere, and the doctor strike in Ontario against extra billing in '86 really consolidates the fear that you can still feel, it's palpable in ministries of health these days, that Luke's talks about 3 dimensions of power. The first one being the obvious one, big guy beats up a little guy, the little guy's afraid of the big guy. The second level of power is where the little guy thinks of something, realizes it will offend the big guy, and doesn't do it. The third, which is where we're at, third level of power where we're at now in Canada, is that ministries of health hardly think of anything that would ever upset physicians collectively. Now, that's not always the case, but in general, you can certainly see that in Ontario, where leading into the last negotiations about the family health teams, the ministry really wanted to do something tough. Unfortunately, they never informed more than 300 people about what was really going on. When push came to shove, a few doctors screamed, and before you know it, the Premier's office is on the phone to Susan Fitzpatrick, the Assistant Deputy Minister, saying, back off. So in 1992, because again, provinces keep on having reports that say that primary health care is important and our current primary health care system isn't working very well, they keep on recommending that we do different things. The Barris-Stoddart report comes out in 91. It makes 51 recommendations about physician services. Most of them are exactly what we'd want: interdisciplinary care, focus on health promotion, disease prevention, on and on and on and on. Also, and yet there's only 2 or 3 recommendations that get implemented. We reduce medical school enrollment, we reduce postgraduate positions. There's a lot of talk at that time, but nothing really happens. And at this point, in fact, in the early 90s, we see Robert Alford, an American analyst from the 60s, had his term is corporate rationalizer. He says that in healthcare, you've got clearly the professions, with medicine most powerful there. And then, of course, you've got what he calls the sort of community voice, which is the people representing the public interest, looking for equity, different ways of delivering services. And then you've got what he calls the corporate rationalizers, administration within the system, within ministries of health, within different health organizations. And those folks can go both ways. They can work with the professions when it's optimal, but they will often use the community voice when they're trying to oppose what the professionals are saying. So in the early 90s, in fact, perhaps in retrospect, the book that Carol Kushner and I wrote in '89, Second Opinion, gets used by the corporate rationalizers to say, we could do much better than we are, we don't need to spend as much money, and so they hack the funding. But they don't really, but the corporate rationalizers don't have enough authority to change the way that services are delivered. So what happens when you take an inefficient system and you just cut it back? It's worse. So nothing happens after Banff and Barris-Daughter. The Chrétien government acts as public spending. The provinces cut health care. And most provinces have major reports on health care, and they create regional health authorities, which are mainly done to rationalize things and in an attempt to save money. The doctor population ratio falls quite precipitously in some places. Family docs stop doing comprehensive care. They stop delivering babies, doing house calls, hospital work, taking call. And as a result, wait lists also tend to lengthen. The feds throw more money into healthcare. But during this time, Senator Kirby puts out reports. There's the Romano Royal Commission. And both Romano and Kirby, although they have some disagreement with each other, say that new money should buy change. But in fact, in 2004, at the Federal Provincial Territorial Accord, Paul Martin signs this health accord saying it's going to heal healthcare for a generation. Turns out he was referring to a generation of gerbils, not human beings. And so pours in $41 billion over 10 years, no deliverables at all. And the provinces, it's so funny to watch the provinces, I was at that meeting, watching the provinces ganging up on the Prime Minister, feeling like they're big guys and everything. They were all guys back then. And then they go home and they get completely mugged by their providers because of course, without any deliverables, they can't say, the federal government actually wanted at some point to put in real criteria for the primary healthcare projects they would fund. But eventually, the provinces beat them down to nothing. Well, how stupid is that? Wouldn't you love to go back home and say, I've got all this money for primary health care, but it turns out that it can only be used for these models. Then you've got somebody else who's done your pre-negotiations for you. Again, the provinces can't think that straight. They're all puffed up with their own importance, and they are shown back home to be as weak as anything. In the meantime, during this time, the Medicare coalition really fractures. And so as a result, the health coalitions, which, I sort of, I go to a lot of different meetings, but, the health coalitions in this country, unfortunately, they're, as always, even in the 50s and 60s, they're labor-led. But the coalitions in the 50s and 60s, labor is led by non-healthcare unions, industrial unions, and they're focused on also a different way of delivering care. Not as much as some of the rest of us, but they're setting up these group health things and they're doing what they're doing in Sault Ste. Marie. But it's not until the 80s, 70s into the 80s, that healthcare gets unionized. And by the time we get to the late 80s and early 90s, the dominance in the health coalitions, it's still labor, but now it's the healthcare unions. And where you sit determines where you stand. And so as a result, they're under threat. Their jobs are under threat. Hospitals are being slashed. Jobs are being moved to the community at 2/3 the pay and no benefits. And so as a result, we get this real confrontation. And I don't know if anybody else in the room was, I was at a meeting in 1992 where we tried to put together the community voice with Kathleen Connors. I organized this meeting where we tried to put together the community voice and the academics on the issue with the labor groups, and nothing happens. It's really painful to watch. So now I'm afraid I am starting to run out of time, so I'm going to have to talk really quickly. So onwards from 2004, governments throw money at healthcare. After the provinces get the money with no deliverable provider, take it all for income, some wait lists have decreased, but accessibility problems continue, and the provinces are talking about primary health care for all. Well, where are we now? This is what the average Canadian believes, because this is what they're told repeatedly. Healthcare costs are wildly out of control. My fellow baby boomers and I will really deep six Medicare when we get older. The only alternative is either to hack services, go private, or do both. And so many people talk about we need an adult conversation, right? And I was like, well, okay, what's your adult conversation? Oh, it's not that kind of adult conversation. It's actually a kid's, it's a joke to have David Dodge, Jeffrey Simpson, and others saying, we need an adult conversation when they've got their facts wrong. So healthcare's share of the economy is not out of control. The aging population won't break the bank. There are affordable solutions to all these problems. You know a lot of what they are. And refocusing on patients and families, primary healthcare reform, including CHCs and other community-based services like home care, the key to health reform. So I'm just going to, that's my headline. So I'm going to skip through some of these slides, which of course I'm happy to send to you folks later today if you want them. But I just want to highlight this. This is the big thing we don't talk about, that overall Canadian government revenues, Canadian governments have slashed their own revenues by almost 6% of GDP in about a 10-year period. That's the equivalent of $100 billion in foregone revenue. Do you think our governments would be having problems if they even kept half of that? So and you can do this thought experiment yourself, turns out if we'd only cut taxes by half as much, we could eliminate all current deficits and still have some left over actually, or fund pharmacare, long-term care, home care, regulated child care for all parents who want it free, get rid of all university and college tuition, build 15,000 units of affordable housing a year, and if you thought we still needed those fighter jets, we could still buy them, and my estimate is twice the price that they're currently estimated to come in at. And of course, aging the population is not the problem, as Bill Dalziel said, it's the healthcare system response. My parents are not asking for a medicine cabinet full of drugs, but they've got one. And so do most of your parents, no doubt, if they're still around. And we've got these terrible problems where when people on the right say this, some people say to me, they're just making this up, aren't they? No, they're not. Our hospital system is pretty much as good or as bad as other countries. If you're going to have a heart attack or a broken leg, there's almost nowhere in the world you'll get as good care as in Canada. But in the community, of course, we've got awful things. Canadians are the most likely to say they can't get care from their family doctor without going to an emergency room, and we're the highest utilizers of emergency rooms as well. So where are we going? Well, there are affordable problems to all our apparently intractable problems, and Tommy Douglas laid them out. And I keep on telling the story about the second stage of Medicare because it gives, it allows us, well, it's true, I think, but also it allows us to retain the pride that we should have in Medicare and in Tommy Douglas as a true champion of Medicare. And to point out that if we'd followed everything Tommy Douglas and others were saying at the time, we wouldn't have the problems we've got today. So my strategy is to claim credit for our side for all the good things about Medicare and to throw all the problems we've got on others. And in particular, the failure to heed Tommy Douglas's talk about the second stage of Medicare, to alter our delivery system, to change the way we deliver service, to focus on, well, his archaic term, preventive medicine, but keeping people. But I would say the second stage of Medicare is delivering health services differently to keep people well. And of course, this is an example of how we're still not doing it. That in Ontario, we have increased the pay of family doctors monstrously. That we've put the average family physician who goes into one of the Ontario family health teams gets an income boost of $100,000 within 3 years. But there's been nothing that the provincial government has been able to measure that is improved as a result of this expenditure. Although I will say my friends who are working in these FHTs are much happier, physicians are happier, and a lot of them are thinking much more creatively about doing their work. And so that's one thing primary health care reform, as it were, in the last 10 years has done. I think that it's opened up a window. And the other thing is that the folks who were fighting Medicare bitterly and who I used to debate with 40 years ago, many of them are gone. And so as somebody said to me last year vis-a-vis physicians adopting electronic medical records, she said, you know, Michael, change is occurring one funeral at a time. So, and that's part of it. You know, I look to see, you know, like in BC, which used to be filled with NHS refugees, doctors who hated the NHS, went to British Columbia where the climate was reminiscent of back home, and then fought bitterly anything around public health care. And I can see in BC that's really changed dramatically. And there are lots of young family doctors who have none of this history, but they're really interested in doing new things. The new capitation models in Ontario have been a disaster, and I think that that's begging people in Ontario and in other provinces to look at alternatives. Why are we still waiting for the second stage of Medicare? This is from a 1987 Ontario report. Won't read through it all, but the italicized portion is what I want to focus on. That we've known what we should have been doing at least since 1972 in Ontario, and we have just had a devil of a time doing what we should be doing. And this is the problem. I'm not, and you know, some of my best friends are doctors, believe me. My wife is a doctor, is a practicing physician. But the problem is that there's no health system in the world that could pretend it's high performing, which doesn't have physicians who've at least organized themselves within an effective group. The group Health Cooperative Puget Sound has got a different model than Kaiser, but at Kaiser, it's a partnership between the health administration plan and the doctors group. Within the doctors group, the discipline is severe. In 1987, I visited a psychiatrist, physician-in-chief at a Kaiser outpatient mental health center. In 1987, he was keeping track of the data, quarterly reports of all the new patients his psychiatrists were taking on. If they weren't taking on new patients, in fact, this psychiatrist is a champion of brief therapies then, if they weren't taking on enough new patients, they get warned, and if they didn't improve their performance, they were gone. The Cleveland Clinic, the Mayo Clinic, they're all like that. Now, in Canada, you can hardly find, you find these little islands where, oh yeah, in one place there's this amazing clinical governance for orthopedics, and if orthopedics surgeons don't reduce their infection rates, then action is taken. It's usually behind the scenes. Cardiac surgery is one of the first to get into that, but it's all hit or miss, and it tends to be at the departmental level. And so we need to start talking openly about this. Our system is a dysfunctional system. What happens in dysfunctional families? Mom is telling the kids, don't mention the war when dad is in the room. Don't get dad upset. And that's the way ministries of health operate, that even when they know the information, they won't put it out publicly. There's no real engagement with the public. Like in Ontario, Susan Fitzpatrick put a bunch of you and people and other people in closed rooms and educated 200 or 300 people on primary health care policy in Ontario. No one else knew about it. So they prevented the Premier's office people from being at those meetings, even though they wanted to be there. And so what happens when push comes to shove, the Premier's office gets a phone call, and then he shuts down the reforms. So, and this really gets to the point. Does the Canadian state really believe it has the legitimacy to restructure the way doctors do their work? We do feel that it's legitimate to pay publicly for health care. Now, why does Canada need CHCs and CHCs need Canada? I don't need to sell you on the first part, that CHCs are the key to the second stage of Medicare. But that we need to look at how we can be more effective together. Pendulums don't just swing one way. And that particularly, I think that we've got another opportunity coming up for a renewed federal look at some of these issues. Mr. Harper will not be there forever. He may outlast me, but he's not going to be there forever. He won't outlast all of you. And I think that we should be spending a fair bit of time thinking about what we're going to do in the next couple of years to prepare for the time when the NDP and the Liberals have a majority of seats in the House of Commons. Oops. I'm stuck. There we are. And I'm just going to, so I would say it is a new morning for CHCs. that we're going to hear, hopefully during this conference, a lot of what's happening at the provincial level. There's wonderful opportunities in places like Alberta. Ontario has managed to be a beachhead in a lot of ways. Quebec, the CLSCs lost their community governance, but are still a really important part of their system. And I think there's a lot of reason for optimism at this point that provincial governments looking at the experience in Ontario are very shy about simply stuffing a huge amount more money into physicians' pockets, hoping that that will reform the system. So in summary, healthcare costs are not out of control. The aging population won't break the bank. Medicare wasn't as good public policy. But the problems in our healthcare system developed because we failed to obey the original vision for Medicare, and follow through to the second stage of Medicare. And unfortunately, many of our progressive friends have lost the plot. People on the left have forgotten where they were trying to go. So the CHCs are the key to Medicare's second stage. You folks are the key to Medicare's second stage. And don't forget, as much as Canada needs you, you need to support what they're doing. So in our next presentation, I know there's going to be much more detail about the current situation, where you all are now, but I hope you won't forget Tommy Douglas's words about the second stage of Medicare. And I close almost all my presentations with this quote, and it cannot be a more appropriate room to make it in. That courage, my friends, it's not too late for us to make a better world. And so thank you for joining me in Saskatoon to make Canada and its healthcare system a little bit better. Thank you.
Thank you, Michael, for educating us and/or refreshing our collective memories about our history, essentially the foundation upon which our present system has evolved from, and for better and for worse, obviously. Somehow, Michael, you make history interesting. Thank you. Now we have part two, which we're going to just roll right into part two because we're running a little behind, plotting the road ahead for CHCs. And so I'll invite Jennifer Rayner, who's the chair of the CACHC Research Working Group, along with Scott Wolf, our CACHC Federal Coordinator, to share some results from the recently completed Pan-Canadian CHC Organizational Survey. Jen and Scott.